Welcome to EMTprep Pulse Check, the podcast where we help you sharpen your knowledge, ace your exams, and stay field ready. Whether you're prepping for the NREMT or looking to stay sharp in the ever-evolving world of EMS, we've got you covered. Each episode brings educational insights, real-world case reviews, and expert tips to boost your confidence, both in the classroom and on the call. Let's jump in. Today we're going to be discussing a very important topic, BLS Airway Management. Let's jump into our lecture brought to you by Josh, one of our content creators. And then afterwards, we'll have some multiple choice questions to solidify the information we review.
Hello and welcome. So this course is going to cover basic life support or BLS Airway Management, very fundamental foundational skill in emergency medicine, arguably one of the most important skills that we have and one we're going to cover in detail here today. So we'll go ahead and get straight into the material. Quick overview of what we're going to cover in this course. Please understand that airway management is a foundational skill in emergency medicine. It is arguably the most important thing we will do for our patients. When you have really critical patients with a lot of things going on, if you can only do one thing for those patients, airway management is a great place to start. Securing a good airway, most important treatment priority. Providing and maintaining an adequate airway is going to be the top priority in any live patient once immediate threats to life have been addressed. So there's a couple exceptions to the airway being most important. One of those is a cardiac arrest patient where maybe chest compressions are more important. Another one is maybe a patient who is bleeding out, who has so much bleeding that they're going to bleed out before we even address their airway. So we say that any patient with a pulse, any live patient, once immediate threats to life have been addressed, the airway is the most important priority. It's the thing we assess for first and the thing we fix first in pretty much every patient. Today we're going to cover airway anatomy. We're going to cover some assessment strategies to determine if we're going to need to intervene. And we're going to talk about the tools we have in our toolbox to secure a patent or adequate airway in our patients through basic techniques. A little bit of background terminology for you. I want you to understand these terms right away so that you aren't confused if maybe you hear these terms down the road. These are terms that unfortunately a lot of times just don't get defined very plainly to a lot of new EMS providers. First term is going to be airway. That simply refers to the spaces through which air will pass. If air moves through it to facilitate ventilation, we call those structures airways. Respiration is a term that strictly refers to the process of gas exchange, of swapping oxygen and carbon dioxide. You hear the term respiration used a lot, maybe a respiratory rate, maybe the respiratory system, but in and of itself, respiration refers to actual gas exchange. Ventilation, on the other hand, refers to the raw movement of air in and out of a patient's lungs. Air going in, air going out, which is usually what we can actually see, is called ventilation. Perfusion is a really important term that really refers to the blood supply to the organs, right? If an organ is perfused, it means it's getting a good supply of blood. Perfusion refers to that delivery of blood, so delivery of nutrients and oxygen to those tissues. Finally, patent. Patent is a term that is often used to describe an adequate airway. Myself, I am breathing spontaneously, speaking in complete sentences. You can see that I have a patent or an adequate airway. A patient who is unconscious, who has vomit in their airway, who is snoring, does not have a patent airway. We're going to need to fix that. So let's go ahead and start today with some basic airway anatomy, some of the anatomical background, so the things that we're going to do in our patients, things that we're going to manage in our patients. Again, airways are going to be the spaces through which air will pass. Our upper airways are going to be structures like our mouth, our nose, and our throat. Lower airway structures are going to be things like the smaller conducting airways in the lungs. The exact cutoff points where we say above this structure is upper airway, below this structure is lower airway, is actually different depending on which textbook you read. There's no consistently agreed upon spots where we say upper airway structures are above this and lower airway structures are below. It's very important to have a basic understanding of the relevant anatomy so that we understand what we're doing, right? We understand what might be wrong with the patient, and we understand what we're actually fixing when we perform the interventions we are trained to perform. So let's go ahead and take a look at some drawings at some of the anatomy in our upper airways we will start with here. Big task of your upper airways that we don't want to forget about is to warm and humidify air during normal breathing. right? So the air we actually give in our oxygen bottle is pretty dry, pretty cold. Patients out in the winter time, same thing. The air is very cold, very dry. And our upper airway structures tend to humidify that air and warm it up so that by the time it gets down into the lungs, it is at a much better temperature, a much better humidity to facilitate good gas exchange. And our lungs really prefer that warm, humid air over dry or cold air when they can get it, right? Cold, dry air will suffice, but it is much less ideal than nice, warm, humid air that we get if air passes through those upper airway structures during normal breathing. Remember, your mouth and your oral airway are also part of your digestive system. So, food content, beverages, they go through the same structures that air goes through, but they go down a different tube, right? So, we have to have a mechanism in place to make sure the right contents go through the right tube. That's very important in upper airways. Notice how much space in these airways is occupied by the tongue, right? There is not a lot of empty space in a patient's mouth. We tend to intuitively think there's just wide open space in the oral airway, but there really isn't unless we're holding it open for a patient. When patients are unconscious, they need airway management. There's not a lot of open space there. We have to open up space for them if we want air to move through those upper airway structures. So take a look at this drawing here. You see this term pharynx over on the kind of the upper right. You see the pharynx there, subdivided into the nasopharynx in the back of the nasal passages, the oropharynx right at the back of the tongue and kind of what we intuitively associate with the patient's throats, and then the hypopharynx right below there. And then sometimes you'll see the larynx defined as the laryngopharynx as well, which is a kind of our voice box structure. Larynx really refers, it's a medical term really for our voice box. Then we start to get into the trachea down below, and we're going to talk about that when we talk about lower airways. But this is a great picture. Feel free to scrutinize it, get familiar with some of the structures that you're seeing here. Here we have another anatomical drawing, some other structures labeled here that might be useful for you. Understand obstructed upper airways are going to prevent normal breathing, right? If our upper airways are obstructed, air can't move through them, and we can't breathe effectively. There's a lot of things that can cause upper airway obstructions. Things like swelling of soft tissues, maybe an allergic reaction, maybe an infection going on that is causing soft tissues to swell, and swelling of those tissues can block off those airways or at least restrict airflow through those structures. Foreign body obstructions, that's a patient who is choking, that will obviously prevent air movements. A loss of airway tone, right? We do a lot of subconscious airway protection on our own, right? We do tend to hold our airways open without even thinking about it. When patients are unconscious, or maybe they have a problem like a stroke, sometimes they lose that airway tone. Sometimes these structures tend to collapse upon themselves and cause an obstruction that we're going to need to manage and otherwise fix for our patients. Patients sometimes won't maintain their own airway, right? An unconscious patient, there's one thing to be asleep. We tend to protect our airways pretty well when we sleep, at least most adults do. Patients who are unconscious because of a head injury or an overdose of recreational drugs or some sort of substance intoxication, whatever reason they're unconscious for, they don't tend to maintain their airways effectively, right? And so we need to scrutinize that. We need to see if we're going to need to manage that airway and make sure that they're able to breathe. Then we have patient positioning. When we talk about management, I'm going to tell you that patient positioning needs to always be your first intervention, right? It's the first thing on your mind, and making sure a patient is positioned appropriately. And that's because a patient who isn't positioned appropriately might not be able to breathe just because they're in a bad position, especially pediatric patients. Sometimes they will just roll over, or they'll be lying flat on a hard surface, which isn't ideal for pediatric patients by any means. And for whatever reason, their airway just isn't positioned appropriately, and so they can't breathe. A lot of times fixing that positioning is the only thing we really need to do, is the most important thing in helping that patient move air effectively. So a lot of things can obstruct those upper airways. We're going to talk about, how to recognize that an upper airway is not doing so well later on. But our upper airway structures is everything kind of in that, at least in your mouth, at least above the level of the vocal cords. But again, the strict landmark where we say upper airways are above this structure, lower airways are below, isn't really well agreed upon. Upper airway structures are pretty easy to control with simple adjuncts, with things like nasopharyngeal airways, NPAs, we'll talk about those. Oropharyngeal airways, or OPAs, we'll talk about those. Those are pretty effective tools at bypassing our upper airways, or at least supporting our upper airways to facilitate air movements. And that's going to be the bulk of the tools you use, right? Is upper airway management devices with our OPAs and NPAs and things like that. Some other devices, things like supraglottic, extraglottic airway devices that we'll touch on briefly today, will completely bypass the upper airways, right? We'll get it to the point where we're delivering air pretty much directly into the trachea. Same thing goes with an endotracheal tube. The more advanced airway management we use, right, the more structures we can kind of bypass and get around so we no longer really have to worry about them. So let's go ahead and take a closer look at kind of a really important region of our airway, which is really kind of our voice box or our larynx area. First thing to notice is the hyoid bone. That is that bone you see in the upper border of this anatomical drawing here. The hyoid bone serves as a rigid attachment point for a lot of these airway structures. It's actually a free-floating bone. Most of the other bones in our body connect to some other bone through a joint. The hyoid is an exception. It just freely floats there in our anterior neck, and it's a rigid attachment for a lot of these airway structures that otherwise wouldn't really, hold a shape. They wouldn't have anything to connect to. The hyoid bone connects all of these structures, holds them into their shape, and is a really important structure. It's something you can feel on yourself, kind of in your upper anterior neck region. The laryngeal prominence, oftentimes referred to as the Adam's apple, particularly in male patients, identifies the thyroid cartilage, which is a good landmark to be aware of. The cricoid ring or cricoid cartilage sits right below that, and in between those two structures is the cricothyroid membrane, which is the target of emergency surgical airway access, usually by advanced level providers, and just an important area of anatomy to be aware of and important landmarks to be able to find in your patient. Take a look here at our vocal cords specifically. This is a really important functional area of our airways that's involved in speech and is important in airway management as well. In adult patients, the vocal cords are the narrowest portion of the airway. In young children, the airways can become a little bit more narrow beyond the vocal cords, lower than the vocal cords. In adults, if something makes it through the vocal cords, it can fit all the way down, all the way until the trachea splits into our main stem bronchi. The epiglottis you see here sits just anterior to these structures on the forward of the patient, right towards the patient's front, if that makes sense. Really important structure. What that structure is designed to do is actually cover our airway when we swallow. As a part of our swallowing reflex, the epiglottis will fold down and cover our trachea to prevent food and fluids and other contents that we don't want going down the trachea from going down there. It really protects our airway. The epiglottis is a potential cause of airway obstruction. A really important thing to be aware of in children, young children in particular, is epiglottitis or inflammation of the epiglottis. It will become bigger and take up space and occlude the airway. Sometimes our airway adjuncts, particularly OPAs, oropharyngeal airways, if they are too long, can actually catch the epiglottis and kind of fold it over the airway where it's supposed to go when we swallow, but not necessarily something we want if we're trying to protect the patient's airway. Right, so that's just an important consideration when you go into advanced levels of EMS and you learn to intubate. The epiglottis is an important structure to gain control of and just something to understand what's going on. Obviously, the vocal cords, hence the term, are involved in speech production. That's what they are there for. They can offer a problem in airway management because obviously we want them to be open. We want to be able to facilitate air movements into the lower airways whenever possible. So we'll go ahead and move down into our lower airways now. Remember, there isn't a consistently agreed upon landmark where we say the upper airways are above this point, the lower airways are below it. Different textbooks, different sources will cite different landmarks, and it really doesn't matter as long as we understand what each structure is there to do. Your lower airways are once again there to facilitate air passage, air movement into the lungs for gas exchange or respiration is the term we use. Airways that do not facilitate gas exchange, that don't swap oxygen and carbon dioxide, are referred to as dead space. So your trachea, your main stem bronchi, most of your bronchioles, they facilitate movement of air, but oxygen and carbon dioxide don't get swapped between your blood and the outside world, and so we refer to them as dead space. There's about 150 milliliters or cubic centimeters of dead space in your average adult, 150 milliliters. Lower airways are a little bit more complicated to control than upper airways. We can't just place a piece of plastic to stent the airways open. We're really confined to medication, so bronchodilators especially, such as albuterol, which is a common medication in the EMT scope, And then pressure support, right? If we can use positive pressure ventilation to blow these airways open, we can support them with some level of pressure support as well. So your trachea is your main windpipe right there in your anterior neck that does sit in front of your esophagus or anterior to your esophagus. The trachea is well supported by cartilage rings in adults, not so much in young children. In young children, it tends to be flexible, it will kink easily. In adults, we have these rigid cartilage rings that keep the trachea open under most reasonable circumstances. Your trachea branches into your right and left mainstem bronchi at the carina, which is that bifurcation you see there. Notice it isn't perfectly symmetrical, so contents that go in too deep, like an endotracheal tube that's overinserted, do tend to end up in the right mainstem bronchus rather than the left, because that's a more kind of natural passage, I suppose. Your mainstem bronchi, you have one for each lung, will further branch into secondary or lobar bronchi. There's one lobar or secondary bronchus for each lobe of your lung, and then those branch into tertiary or segmented bronchi. Those are also well supported by cartilage in adults. Your initial divisions of your bronchi are well supported by cartilage in adults. Again, not so much in children, where all of these structures tend to be softer and more prone to collapse under unfortunate circumstances. Some textbooks will kind of define fourth, fifth, and sixth order bronchi. Kind of just depends on the textbook, once again, when we start to refer to them as bronchioles. But eventually they divide enough and they are smaller. We call them bronchioles, which are not supported by cartilage in adults or children, right? So those structures will collapse upon themselves if things go wrong. Your terminal bronchioles are the most distal portion of what we call our conducting airways that don't facilitate gas exchange. The other term we can use is dead space. Further division of your terminal bronchioles results in respiratory bronchioles, which do facilitate a little bit of gas exchange, and your respiratory bronchioles lead to your alveoli, which are these kind of grape-like sacs of lung tissue where actual gas exchange takes place. Your alveoli are really the functional unit of your lung tissue, and we're going to scrutinize those in detail in a moment here. So if we were to trace the flow of air through our lower airway structures, this is a relatively common test question just to test your understanding of where air flows through the lungs. Starts with the trachea, goes to the mainstem bronchi, to the secondary or lobar bronchi, then to the tertiary or segmented bronchi, may further subdivide into fourth, fifth, and sixth order bronchi. Then when they further divide, we call them bronchioles. Those divide until we call them terminal bronchioles, which are the end of our conducting airways, the end of our dead space. Those divide into respiratory bronchioles, which lead to our alveoli, which are the termination of our lower airway structures. That's where our airways end. Let's go ahead and scrutinize our lower airways just a little bit, in particular our bronchioles. The size of these lower airway structures is really tightly controlled by smooth muscle. When the smooth muscle in these structures contracts, it lowers the size of the airway, right? So you see that big lumen on the left of the picture, the big tube on the left, much smaller tube on the right because that smooth muscle has contracted and lowered the size of that airway. Sometimes this can result in a medical emergency. That's a lot of our asthma attacks, a lot of our anaphylaxis, exacerbations of respiratory disease in general. Terms for constriction, especially when we don't want it to happen, terms for some constriction of that smooth muscle are going to be bronchospasm, bronchoconstriction, or hyperresponsiveness is another one. That bronchospasm, bronchoconstriction oftentimes leads to wheezing, which is a lung sound we hear when patients are really struggling to move air in and out. We will hear patients getting wheezy in things like asthma attacks and chronic obstructive pulmonary disease exacerbations, COPD exacerbations. We hear wheezing because of that smooth muscle contraction through the lower airways. Hyperresponsiveness refers to exaggerated airway protective reflexes that occur in a lot of airway disease, a lot of asthma attacks, again, COPD exacerbations. When they have this relatively sudden onset of lower airway constriction and wheezing, we call that a hyperresponsive airway reflex or hyperresponsiveness, which is kind of a hallmark presentation of lower airway diseases like asthma and COPD and things like that. These smooth muscles are the target of our bronchodilator medications. Albuterol is probably the most common bronchodilator medication we use. It is specifically a beta-2 agonist. That probably doesn't matter too much for you yet, the specific mechanism, But bronchodilator medications target the smooth muscle in the lower airways and cause it to relax, to open up the airways, to make it easier to move air in and out of the lungs. These are the target of our bronchodilator medications. Really important to kind of understand how that works, how smooth muscle contraction makes those lower airways smaller, smooth muscle relaxation makes those lower airways bigger and makes it easier for the patient to breathe. Now we can scrutinize those alveoli. These are the functional units of our lung tissue. This is where the bulk of gas exchange is going to take place. The purpose of alveoli is to maximize the amount of surface area so that air can come in contact with our blood, so that oxygen can move from the air into our blood, and so carbon dioxide produced by our metabolism can leave our blood, get into the air so that we can get rid of it into the atmosphere. There are millions of alveoli in adult lungs. They are microscopic structures. We blow them up for the purpose of explaining how they work and looking at them, but these are microscopic structures that you would need a microscope to see. Definitely nothing you can see with a naked eye by any means. These are well perfused by capillary beds. Again, that's the point, is to maximize that surface area, maximize contact between our blood and the outside world to facilitate gas exchange. Oxygen moves from the atmosphere into our blood, CO2 moves from our blood into the atmosphere, and that is how we exchange gases. That is how respiration works. The vast majority of gas exchange happens in these alveoli. These are those kind of grape-like sacs of lung tissue where actual gas exchange takes place. The membrane that takes place across is known as the alveolo-capillary membrane. Alveoli are elastic. They're kind of like little balloons or bunches of balloons, and they do naturally deflate themselves under normal circumstances. They should be very elastic, and so lungs tend to deflate themselves. Understand, in normal breathing, we do work to pull air into the lungs, but exhalation, air movement out of the lungs, is really just passive because the alveoli will deflate themselves. Complete collapse is prevented by contact with the chest wall, right? The chest is an airtight seal, so our lungs can't really collapse themselves, because they're constantly held against the chest wall. If we didn't have that, right, if we have a pneumothorax, we have air leaking into the chest, the alveoli can start to collapse upon themselves because they are stretchy and they tend to close themselves naturally. Your alveoli do come lined with a surfactant that prevents unwanted collapse. If they didn't have that surfactant, the surface tension of water would actually have those alveoli fold in on themselves, and random alveoli would start to collapse upon themselves and make it very difficult for a patient to breathe. So alveoli come lined with a surfactant, kind of a soapy, slippery substance. When patients cough it up, that tends to be very pink and frothy. You can recognize they are losing that surfactant. But that affects the surface tension of water in such a way that these alveoli are held open under normal circumstances. So let's go ahead and talk about some of our assessment strategies for determining if a patient has a good airway, or if we're going to need to intervene in some way and maybe give them a good or patent airway. As I've kind of said before, assessing for and securing a patent airway is the very first step in most patients. This is the first step of what we call the primary assessment that usually starts with addressing any immediate or obvious life threats, and then we move on to airway, breathing, and circulation, the ABCs as we call them. Very important treatment priorities in our patients, right? And airway comes first. It's the most important thing we do for the vast majority of patients who need this problem to be fixed. If an airway is normal, it allows for sufficient airflow, we can go ahead and describe that as patent. In a lot of patients, this is very quick. Your patient called for chest pain or abdominal pain. They're breathing spontaneously, speaking in complete sentences, clearly protecting their own airway. Immediately you know they have a patent airway. Other more critical patients, unresponsive folks, major trauma patients, we need to do a little bit more assessment and maybe some airway management on those patients. Anytime an airway problem poses an immediate threat to the patient's life, we're going to intervene immediately. This isn't just something that we note and take care of later down the road. Anytime you find an airway problem with a patient, you intervene immediately. So airway assessment and management really go hand in hand. We discuss them separately, but if you identify an inadequate airway, something like a foreign body obstruction, snoring respirations, a patient who can't move air, they don't have good airways, we're going to fix that problem as best we can immediately, right? And if something comes up down the road, we're going to intervene immediately the second we identify an airway problem. Finally, understand that airway assessment is a continuous process. This isn't something that we just address one time. We need to continuously make sure our patients have a good or patent airway. If something changes down the road during patient contact, we once again fix it immediately. This is a continuous process of airway assessment, making sure our patients are able to move air without any difficulty. So let's talk about some signs that a patient has a good or an adequate airway. And a lot of patients, it's pretty quick, pretty obvious that they don't need us to do any aggressive interventions. One of those is a patient who's alert and can breathe or ventilate easily. They're easily moving air, they're speaking in complete sentences, having a conversation with us, which is probably the vast majority of our patients, right? They might call 911 for an extremity injury. Maybe they call 911 for chest pain, abdominal pain, any of the medical emergencies patients might call 911 for. If they're talking to us just fine, breathing easily, alert and oriented, we can probably quickly say that that patient has a patent airway. Speaking in complete sentences, speaking in their normal voice, no obstructions of any kind, no problems whatsoever, we can go ahead and say that's a patent airway very quickly in a lot of patients. Now let's talk about signs of an inadequate or a bad airway. Agonal, labored, or ineffective breathing. Agonal breaths are breaths that patients take really when they are dying. It's something you will learn to recognize through patient contacts, and it's a word that should always cue you in to an inadequate airway. Labored breathing refers to a patient who is struggling to move air. Breathing is something we should be able to do pretty much effortlessly. We shouldn't use a whole lot of energy just moving air in and out. If a patient is working really hard to move air, chances are they have an airway problem, or they may very well have an airway problem that needs to be addressed. And then any ineffective breathing, any breathing that is outside of a good rate or depth, volume, that's an indication that the patient might have an airway that needs to be fixed. A lack of air movements means a patient is not moving a sufficient amount of air, tells us they might have an airway problem. Any patient who is unresponsive or severely altered, we're going to presume they aren't protecting their own airway. A patient who is alert and oriented times 4, they know everything, they can answer all of our questions, they're a normal, average, alert person, chances are they're protecting their own airway just fine. They can hold their airway open. An unconscious patient probably can't, so that's an airway where we might need to manage it. Snoring or gurgling sounds are cues that tell us there is a problem. Some patients snore while they sleep. It's not ideal to begin with. Patients who snore while they're unconscious from a traumatic injury or medical emergency, it's even more concerning. Snoring tells us that the soft tissues in those airways are collapsing, and a patient does not have a patent airway. Gurgling sounds oftentimes reflect a fluid obstruction that needs to be suctioned out, all signs of an inadequate airway. Then adventitious or abnormal lung sounds. Adventitious is kind of a blanket term for bad lung sounds. Some specific lung sounds that tell us of an airway problem are going to be stridor and wheezing. Stridor is a very high-pitched lung sound that reflects an upper airway obstruction. When you hear stridor, you should think upper airway obstruction. Wheezing is a lung sound that usually tells us we have some constriction of our lower airways, or a lower airway obstruction. That's your asthma attacks, your chronic obstructive pulmonary disease exacerbations, COPD exacerbations, sometimes anaphylaxis. A lot of patients who might be wheezing, that tells us there's a lower airway obstruction taking place. Any airway swelling, so patients with burns, right? We expect those burns to cause airway obstruction in the near future. We treat them pretty aggressively. Things like anaphylaxis, soft tissue injuries, inflammation for any reason, that can cause airway obstruction very quickly. And then any other known obstruction of any kind. If they have a foreign body obstruction, if they're choking, it's pretty obvious that they do not have an inadequate airway. So let's talk about an upper airway assessment, right? How we determine if a patient is able to move air through those upper airways. One thing we can do is just listen and observe that patient's breathing for a few moments. If we see snoring or stridor, that immediately tells us there's an upper airway obstruction. Snoring tells us those soft airway structures, those soft tissues are collapsing, the patient's not maintaining their airway. Stridor tells us we have a pretty severe upper airway obstruction. That's a lung sound you should always learn. Then we open that airway up, right? We open that patient's mouth and we always take a peek inside that airway. Look at their tongue, look at their other soft tissues, see if there is swelling, see if that tongue is fallen back into the throat. Look for visible foreign bodies. We do not recommend any blind finger sweeps these days. You can remove any obstructions that you see, but if you just think there's an object down there and you can't see it, we're going to leave it alone because we don't want to push that obstruction even deeper down their airway. And then other big things, right? Food, blood, vomits. Might throw dentures in there or just dental material in general. If we see materials in the upper airway, we want to remove them either by grabbing it, throwing it out of their airway for things like a glob of food that you might find in there, or suction for things like blood and vomitus that are going to pose an airway obstruction. Moving down to our lower airways. When we assess lower airways, we're really listening, right? We're listening with the stethoscope for some of those adventitious or problematic lung sounds. Wheezing is a lung sound that indicates constriction of the lower airways, right? So some level of bronchospasm when that smooth muscle contracts in those lower airways and makes them smaller. A lot of those patients will end up wheezing. Crackles or rowels, you might hear them called, indicate pulmonary edema. That tells us there is fluid in those lower airways that shouldn't be there, and that's a problem that might need to be addressed. Auscultates to identify air movements throughout the lungs, right? Diminished or absent lung sounds tell us there is a lack of airflow. Really severe exacerbations of respiratory disease, you will hear lung sounds disappear, especially in the lowers. When we auscultate, when we listen for lung sounds, it's really important to listen to at least a few different spots in both lungs to listen overall, right? To get an overall picture of what's going on. When we hear diminished, absent lung sounds in the lower portions of a patient's lungs, tells us air is not making it through, which tells us they probably have at least a lower airway problem going on. So that's assessment, right? Assessments can be pretty quick. We can very quickly identify if a patient has a good airway or not. Let's talk about how to fix it, right? How to actually secure an adequate or a patent airway in a patient. First thing we're going to talk about is personal protective equipment. I'm recording this in the middle of a pandemic where we're using a lot more PPE certainly than we did a year ago, but there are some considerations when we're doing airway management. We want to protect ourselves a little bit more than we do just as a standard for an average patient contact. We're going to talk about a fundamental background skill in airway management, which is patient positioning, something we never want to forget about. I'm going to talk about suctioning, manual airway maneuvers, some of the adjuncts, the things we put in an airway to secure it, and how to relieve a foreign body airway obstruction, which you probably learn when you get your BLS or your CPR card. So let's talk about PPE, right? Airway management does require a little bit of extra personal protective equipment. Again, outside of any pandemics where we're wearing a lot of this stuff by default, kind of standard in most EMS systems is EMS gloves and maybe some safety glasses, right? We don't wear much more than that on our routine patient contact. If you're up there in a patient's airway, you should be wearing a little bit more than that, right? A lot of airway procedures are going to generate very small respiratory droplets. Some procedures, we can call them even aerosolizing procedures, where they make microscopic respiratory droplets. A lot of airways are full of vomit and all sorts of infectious pathogens that we do not want getting all over our face and in our own airways. So we need to wear a little bit of extra safety equipment to keep ourselves safe. Providers should really be wearing at a minimum, if they're doing airway management, they're up in a patient's airway, they should be wearing medical grade disposable gloves. Those are standard on all patient contacts. They should really be wearing a mask and ideally an actual respirator, an N95 or a P100 or even a better respirator, so that we're not getting those tiny respiratory droplets in our own airway, putting ourselves at risk of some pathogens. Should be wearing full face and eye protection, right? So safety glasses to protect our eyes, and ideally a full face shield like you see here. Those are very common during the pandemic, and that protects our face from any splatters, any droplets coming out of that patient's airway, which happens quite often once you get some hands-on experience in airway management. We get droplets going everywhere. We do not want those on our face. We want those getting caught on a face shield or some sort of protective device. Another thing you might consider is an isolation gown, right? We're protecting our face, we're protecting our airways. You might want to protect the rest of you as well. Protect the clothing you're wearing, protect yourself with an isolation gown. So anything coming out of that patient's airway, if they're vomiting, which is very common in things like cardiac arrest patients, if there's blood in that airway, if you're suctioning and blowing droplets everywhere, we want to protect ourselves with a lot more personal protective equipment than we normally wear. And just make sure you have the confidence to take a couple seconds to put some of these things on. At least, a mask and a face shield on top of your normal personal protective equipment. Number one step in actual airway management is always going to be patient positioning. Proper patient positioning is going to create a foundation for effective airway management. And this is the step that is probably most often forgotten. Once you get out of EMT or paramedic school, get out there in the field, you will see that people oftentimes forget this step and really set themselves up for failure by not positioning a patient properly. We tend to practice in EMS on airway mannequins that come pre-aligned. A lot of the mannequins you will see come pre-aligned. They're in a great sniffing position already, and we can really form some bad habits about forgetting this piece of airway management. When it comes to conscious patients, they're usually going to benefit from a high seated position, even leaning forward a little bit. If your patient is conscious, they can position themselves or we can help them position themselves. Usually a high seated position is a good move for any sort of respiratory patient. Unconscious patients, on the other hand, we want to put them in a slight sniffing position. Kind of like you see in this photograph here. What we want to see is we want the ear canal to be on the same horizontal plane as the sternal notch high up on that patient's chest, and we want their head rolled back just slightly so that they're kind of in a sniffing position. Very important position to remember in a patient of any shape or size. That slight sniffing position is absolutely critical in effective airway management. Putting a patient in a good position sets us up for success in every single thing that we do down the line. It's going to be easier to suction them. It's going to be easier to insert things like OPAs and NPAs. It's going to be easier to do everything if you position your patient appropriately. So, like I kind of said, real patients don't really come aligned like our airway mannequins do. So the goal is that ear canal to sternal notch position. Pediatric patients, young children, typically require elevation of the shoulders. Young kids have really big heads that tilts their head forward, and so we have to kind of bring their shoulders back up to put the ear canal in line with the sternal notch. Obese patients are kind of the opposite. Obese patients tend to have really thick chests, and so their head falls back a little bit farther than we want it to. And so for those patients, we have to elevate their head. A lot of times we'll actually kind of make a ramp of padding from their shoulders to their head so they can get their shoulders up a little bit, let their head roll back slightly to put themselves in that nice slight sniffing position. Please understand that airway devices are not a good substitute for this proper airway alignment. You can't really fix a positioning problem with something like an OPA or an NPA. This is a skill that really has to happen in every single patient, right? We can't forget about this because if your patient isn't positioned appropriately, everything else you're going to do is going to be more difficult. So this is a really important thing to focus in on. And never forget to put your patient in a good, slight sniffing position. So, pediatrics, like I touched on, they typically require elevation of the shoulders for a good alignment. Looking at the picture you see on the slide here, a trained eye can kind of recognize that that patient's head is tilted forward just slightly, which is pretty common for young kids. That's not an extreme case. You might be able to get away with that airway, but it'd be a lot better if we could get just a little bit of padding under those shoulders to let that head roll back just slightly in what we call a sniffing position. All right, so grab a rolled towel, a rolled sheet, a book from a bookshelf in a patient's house if you need to. Bring those shoulders up just a little bit. Put something under that patient's chest to put them in that good airway alignment. Unfortunately, a lot of pediatric mannequins will simulate this by default, which just forms bad habits for us. It encourages us to forget that this is a problem. So look at your pediatric mannequins that you're practicing on. A lot of times you will see a little simulated block, a simulated towel, simulated book placed under the shoulders. We don't want to forget to do that, all right? That needs to be the number one thing on our mind when we're doing airway management, is patient positioning. Obese patients, like I said, they have a big old chest wall, right? Their chest wall is a lot thicker and so we might need to bring their head back up a little bit because that thick chest wall will cause their head to fall back and put them out of a good airway alignment. A lot of providers will train to use kind of a ramp of padding. You can even use a pillow, fold a pillow, and create a ramp of padding that way, but put their shoulders up a little bit and allow their head to fall back on that ramp of padding, again to put them in a nice slight sniffing position. You want the ear canal in line with the sternal notch with some slight extension or slight rolling back of the head. Another thing that might help with obese patients is elevating the head of the bed just a little bit. So we're going to talk about two first-line airway maneuvers that you're going to be taught in any level of EMS provider, EMT all the way to paramedic. First one of those is a head tilt chin lift. The goal here is to roll the head back slightly and open up that patient's airway. This will help you with that airway alignment just a little bit. What we're going to do is we're going to push down on the patient's head to cause their head to roll backwards, and then we're going to push upwards on the jaw. Photo here is showing a great example of how this works. One patient population where we want to avoid this is those who require cervical stabilization. A major trauma patient where they might have broke their neck. We do not want to manipulate their C-spine whatsoever. So this is really for our medical patients exclusively. We don't generally want to do this on trauma patients because we risk causing an injury or exacerbating an injury to their cervical spine. The next one is a jaw thrust. Very important airway maneuver to remember. The goal here is to facilitate anterior or forward motion of the jaw. So if the patient is on their back, we're trying to move their jaw towards the ceiling. So think about giving the patient an underbite. We want those bottom teeth to protrude past the top teeth. This is the first line maneuver in trauma patients, but really important to understand that this is not just for trauma patients. A jaw thrust can benefit just about any patient you're managing an airway on, but this is the only maneuver we use in trauma patients because we don't want to do that head tilt chin lift because we don't want to manipulate their C-spine, and a benefit to this maneuver is that it does not move the C-spine. The goal here is to increase the available space in their oral airway, pulls that tongue off the back of the throat, and this maneuver actually directly pulls on the vocal cords. It actually puts the vocal cords into an open position, which is really helpful for providers who are trying to intubate a patient, and is helpful even if you're using basic airway management. Jaw thrust benefits pretty much every patient. It is not just for trauma patients, but it's the only basic maneuver we do in trauma patients, if that makes sense. Another maneuver you might learn is a tongue jaw lift. I believe this is still on the skill sheet for supra or extra glottic airway devices. The goal here, once again, is to facilitate some jaw thrust and facilitate an open airway. What we do here is we grab the patient's jaw, we insert our thumb, we grab the patient's tongue with our thumb, and we grab a handful of airway, grab a handful of jaw, and pull that upwards once again towards the ceiling, facilitating a little bit of jaw thrust. Most common time you're going to be taught this is extra or supraglottic airway devices, things like king tubes and eye gels, depending on the local equipment that you use and that you're trained to insert. Another one is kind of a scissor maneuver, a scissor technique. Way I like to think about this is kind of snapping your fingers. All we're trying to do is open up that airway and increase the available space to get some work done. Grab your thumb and middle finger kind of like you're snapping your fingers, and then use those two fingers to pry open that patient's mouth. You got your middle finger and thumb on the patient's teeth. The middle finger on their upper teeth, your thumb on their lower teeth, and you're opening up that patient's mouth. Moving on to suction. Suction's a very important skill in emergency medicine because nasty airways tend to come with a lot of blood, a lot of vomit, lots of secretions of various types, right? And we want to remove those as soon as we can. Fluid obstructions are pretty common, right? Things like blood, vomitus, just a whole bunch of saliva, things that we want to remove so that our patient can breathe, that they aren't drowning in those secretions. So we use suction devices in emergency medicine that are designed to safely remove those fluids from the airway. You work with these a lot in EMT and paramedic school. Just remember, when you get on real calls, we have to remember to bring this to the scene. We don't necessarily bring suction into a chest pain call, but your unresponsive, unconscious patient, your respiratory patient, we got to remember to grab that suction device and bring it into the patient's house. Your general procedure with suctioning, this is something that is a lot easier to work on with hands-on skills labs. But once again, patient positioning is number one so that we can get access there. Pre-oxygenate the patient when possible. If their mouth is full of vomit and blood, chances are you're not going to be able to get a lot of oxygen in there until you remove those fluid obstructions. But when we can, we want to pre-oxygenate our patient because we do risk sucking oxygen out of their airways with suction. You're going to prepare your equipment as it's designed, whatever equipment you are using. We're generally going to insert a device without suction to the appropriate depth with whatever protocol you are using. And then you are going to suction the mouth and oropharynx. You're going to suction that airway on your way out for less than about 10 seconds at a time. If we need to suction more than that, we'll usually take some breaks and pauses. Just kind of depends on the specific protocols you're using, but we generally want to keep suctioning to about 10 seconds at a time because we're not trying to suck too much air out of their airways and take away their oxygen. Rigid tip suction is kind of what you see here. That's what you might be experienced with in the dentist, right? That's what they go into your mouth when they're cleaning off of your teeth and that stuff. Rigid catheter just refers to a tip that we can kind of direct where we need it to go, right? Most of these devices are going to require us to place our finger over some sort of hole to close the circuit and create suction. So we can insert the suction device without suction, apply your finger to the hole to apply suction so that we can suction on our way out. We're going to suction our oropharynx, our oral airway, or the patient's oral airway, I should say, to remove any of those obstructions. One important consideration with these is seizure patients. We never put anything in between the teeth of patients who are actively seizing. So you would never put this tonsil or rigid suction tip in between the teeth of a seizure patient. You can go on the sides of their cheeks, around their teeth in some cases, but you never want to put it in between the teeth of a patient who is actively seizing. Other patients, this is kind of our go-to. Soft suction, on the other hand, is kind of a flexible suction catheter, right? It can't be easily directed where we need to go. And this is really used for advanced airways, so king tubes, eye gels, endotracheal tubes, and in some cases, nasopharyngeal airways, kind of soft tubes that we will place in a patient's nasal passages, which we'll discuss in a moment here. A lot of times these get confused with gastric suction devices because they look very similar. So it's really important to recognize the equipment that you have in your school or the agency you respond with to make sure you're not inadvertently placing a gastric suction tube into an airway, right? Because these are two different types of devices. We've got to close the circuit just like a rigid suction catheter. In the photograph you see here, right by that person's left hand, you see a little open hole there where they can cover it up and apply suction. That's how these work. Avoid suctioning too deep. Always follow your protocols for the intended depth for whatever airway device you are using. That is going to depend a lot on your local protocols, your local scope of practice. And then one technique you see here is they have a little, basically a bin, probably full of saline or sterile water. And sometimes that can help us. If we suction a lot of mucus, a lot of nasty stuff out of an airway, we can then put that suction catheter in some sort of fluid, suction a little fluid out to make sure that nothing crusts up and occludes our catheter. So now let's go ahead and talk about our simple airway adjuncts, which is really going to be OPAs and NPAs, very important airway devices in basic airway management. These are very simple devices that are used to very quickly secure a decent airway in a patient with an upper airway problem. Right, so we use these in patients who don't have a patent upper airway. These don't really fix a lower airway problem. These really fix upper airway problems. Two main types of devices, that is oropharyngeal airways, or OPAs, which is the one you see on the left in this photograph, and nasopharyngeal airways, or NPAs, which is what you see on the right of this photograph, that green tube going around the patient's nose. We'll talk about OPAs first. These are rigid, kind of plastic devices that are simply designed to hold the tongue away from the back of the throat, to get the tongue out of the way so we can have some space for air movement through that patient's mouth. There's a few different methods out there for sizing. Use whichever one you are taught for your local area and your local protocols. Center top teeth to the angle of the jaw is a common one. Corner of the mouth to the tip of the earlobe is another really common one. Just use whatever sizing method you are taught in your area. We always insert these devices at an angle. So we don't just insert them straight in at that angle you see they seat. We insert them either at a 180-degree angle, kind of upside down, or at least at a right angle. The goal is to make sure we aren't grabbing the tongue with these and cramming the tongue in the back of the throat. which is something that can happen. So open the patient's airway, suction if needed. While that airway is open, insert this device in a way that does not move the tongue and push the tongue into the back of the throat. It's important to understand that these devices are not definitive airways by any means. We still need a full face mask, a full mask seal around the patient. You don't breathe directly through the OPA. It's simply a piece of plastic designed to keep the tongue off the back of the throat. The other main device we use are nasopharyngeal airways, or NPAs. These are relatively suction tubes. Sometimes you will hear them called the nasal trumpets. That's kind of an old school term, but it's a flexible tube that's designed to support the nasal passages, support the nasal airways. Biggest thing that people get caught up on with these and inserting them improperly is when they try to insert them going upwards. The nasal passages, when we looked at those anatomical pictures, they actually go straight back, right? So we insert these towards the patient's ears, not up towards their forehead or their eyeballs, because they're going to get stuck that way. They're not going to insert appropriately in that way. We can insert these in either or both nostrils. You will generally be told to insert it with the bevel facing towards the septum, bevel facing towards the center, but we can insert NPAs in either or both nostrils. You can actually use 2 of these if you want. These are the preferred airway device in patients with a gag reflex. If these are long enough, they will trigger a patient's gag reflex, but if they're small enough, they will not, and we can actually use them in patients who do have a gag reflex, which is very helpful for us in kind of altered patients, unresponsive patients who will still gag on an OPA. We can go ahead and use an NPA. Big contraindication for these is going to be any major head or face trauma, oftentimes bleeding out of the nose, because we don't want to exacerbate any injuries, and there are a couple isolated cases out there of these actually going into a patient's brain if there's enough bone damage right behind where we're inserting them. So we avoid them in any major trauma patient, really intended mainly for our medical patients. But these are very helpful devices. They support those nasal airways and allow good air passage into the back of the throat. So let's go ahead and talk about our face mask technique. This is one of the more difficult skills in EMS, something that's maybe easy to do on a mannequin, not always so easy to perform on a real patient. Any simple airway, right? So if we're using OPAs, NPAs, we're not using any definitive airway, we need to use a full face mask to facilitate ventilation, facilitate air movement in that patient. Like I said, oftentimes this is pretty easy on our mannequins that are designed for training. You get a patient with a lot of facial hair, anatomical differences, funky facial anatomy. This becomes very difficult on real patients out there in the field, and it's something we really need to practice a little bit more often than we do, to be honest. Anytime we're using a face mask, we want to have our priority on pulling up rather than pushing down. You never want to push down on a patient's airway because that'll actually push their jaw towards the back of their throat and potentially occlude their airway worse off than it was before. So we always focus on gently placing that mask on the patient and pulling up, pulling their face into the mask, pulling their jaw upwards into the mask to create that mask seal. The power should always come kind of from our grip strength of our hand, not any sort of pushing motion, because we do not want to occlude their airway. It's a very difficult skill, like I said, one of the more difficult skills we do in airway and breathing management, something that takes a lot of practice to really get done right. You always want to hold the bone of the jaw, not any soft tissues. Providers can get in a really bad habit of digging their fingers into the soft tissues of their neck and the throat, which can actually cause an airway obstruction. We always grab the bone of the jaw, pull that jaw upwards into the mask. And it's very important to get a good mask seal. You got to choose a mask that is the appropriate size. We need to cover the entire nose, the entire mouth, and secure that patient's airway, right? In your average adult, your adult mask will do just fine. When we get young pediatrics, sometimes we have to use a different size mask and take a couple moments to choose the appropriate size of mask. Couple grips I will teach you here. You'll probably learn even more than this. The CE grip is kind of the standard of care for single rescuer ventilation, and that's what you see in the photograph here. We make a C with our pointer finger and our thumb, and we use our other 3 fingers to kind of form an E, we call it. We grab the jaw with those 3 fingers, grab the mask with our C with our first finger and our thumb, grab the jaw that way. All right, we pull or squeeze the jaw into the mask. Never ever want to push down because that's going to occlude the airway. Next grip is the TE grip, which is very strongly preferred anytime there is a second rescuer. When you're on a medical call with a whole bunch of crew members on scene, which is pretty common if you have enough crew members in your EMS system, this technique is a lot more effective. There's a lot of research behind it that we should really be moving towards this grip anytime we have a second rescuer available. It's also called the two thumbs down technique. Notice this provider here has their thumbs pointed towards the patient's feet. You use your thumbs on the side of the mask to hold the mask, and then you have four fingers on either hand to grab that patient's jaw, pull their jaw up into the mask. If you can incorporate jaw thrust into this maneuver, anterior motion of that jaw, it's going to benefit your patient, right? Grab the jaw with both hands, your thumbs on the mask, squeeze their face, pull their face into the mask, and airway management is a lot easier in this case. You're a lot more likely to get a good mask seal. You're a lot more likely to get good ventilation than you are with a simple CE grip. Again, this requires two rescuers because two hands have to be on the mask, but this is a lot more effective, a lot more successful when the research has been done on it. Moving on, we'll touch briefly here on supra or extraglottic airways because they are sometimes in the scope of an EMT basic, and they're very effective airways. They're a lot more definitive than simple OPA, NPA with mask ventilation because these will do a better job of securing the airway directly, right? And with these, we no longer have to use a face mask. That's one of the huge benefits. We no longer have to use that face mask, and we can just attach our bag directly to this airway device. Anytime we're using advanced airways, we have to confirm placement both with lung sounds and with end-tidal CO2 if you have that capability or some other secondary confirmation device. This is really something to learn based on the skill sheet, the specific equipment you use in your EMS system, but these offer a more definitive airway than a simple OPA or NPA and can really secure the airway, kind of bypass those upper airway structures completely. Next up is CPAP. CPAP stands for Continuous Positive Airway Pressure. A similar device, BiPAP, stands for Bilevel Positive Airway Pressure. And those are collectively referred to as non-invasive ventilation, or NIV. Most common piece of equipment you're going to see in EMS is going to be CPAP. A lot of patients will use CPAP when they sleep. That's a little bit different than the devices we use, but it's the same concept. Patients will help with their airway management. It will keep them from snoring. It will help them breathe better when they sleep because they have that continuous positive airway pressure. That positive pressure provides inspiratory support. It helps the patients breathe in, and it allows them to breathe out against a resistance. CPAP is both airway management because it holds those airways open with pressure from the air. It blows their airways open, both their upper and lower airways. And it's also ventilatory support. It helps the patient breathe. It helps them exchange gases. CPAP is a very important tool we have in EMS. It's a very important skill to be comfortable with, and another one where you want to practice with the equipment you're going to use with your EMS agency or your school and follow the specific protocols that you have. Now we can talk about relieving foreign body airway obstructions. This is something you probably learn when you get your basic life support card, your CPR card for healthcare providers. Very critical for us as healthcare providers to be able to identify a foreign body obstruction and remember how to fix this. Thankfully, this is usually something that's done before we get there. Usually foreign bodies are out. They are no longer obstructions by the time we get there, but sometimes we do get tasked with relieving a foreign body obstruction. Interventions that we're teaching are abdominal thrusts or chest thrusts and back slaps are intended for complete or severe airway obstructions. These are intended for patients who cannot breathe, they can't talk. If your patient is talking, breathing, crying, we probably don't need to do these invasive procedures. Conscious patients are going to require abdominal thrusts or chest thrusts and back slaps. Unconscious patients, this is a very common test question. Unconscious choking patients require CPR whether or not they have a pulse. If they have an airway obstruction and they lose consciousness, they get CPR. Abdominal thrusts we'll discuss first. The goal here is to place an upward pressure on the diaphragm. A lot of times we'll teach to get behind the patient, put your fist between their belly button and their sternum, and put your other hand on top of your fist and pull inward and upward forcefully. Again, we're trying to put an upward pressure on the diaphragm, put positive pressure on the airways, and push that obstruction out of the patient. This is a continuous process. This is not a one time, it's not one abdominal thrust. It is abdominal thrusts. We continue this procedure until the patient either loses consciousness, at which point we will perform CPR, or that obstruction clears and the patient can all of a sudden talk and speak and cry, whatever it is. If the obstruction is relieved and they are still conscious, we reassess. If they lose consciousness, we immediately start CPR, regardless of whether or not they have a pulse. Remember, common test question, unconscious choking patient, the indication is CPR. For infants, for kids under about 1 year of age, actual babies, we instead of abdominal thrusts, we do this chest thrust and back slap progression. So we do 5 back slaps, 5 chest thrusts, and repeat. Once again, this is for conscious infants only. If they are unconscious with an airway obstruction, we immediately begin CPR, whether or not they have a pulse. If they are conscious, we perform this continuously until that obstruction is removed or they lose consciousness, where we start CPR. So we're getting towards the end here. Let's talk about a few terms that we always want to remember in EMS, right? Terms we don't want to be confused about, terms we want to immediately remember. One of those is airway. Remember, airway refers to the spaces through which air passes to facilitate gas exchange down in the lungs. The spaces where air goes in and out are airways. Respiration refers to the process of actual gas exchange, either at the alveolo-capillary membrane in the lungs or in the target tissues. Gas exchange is respiration. Ventilation refers to the raw movement of air in and out of the respiratory system. So air going in, air going out. That is ventilation. Perfusion refers to blood supply, right? Refers to blood providing that tissue with nutrients, oxygens, the things it needs. Perfused tissues are getting a blood supply. Patent refers to an adequate airway. If I'm talking to you breathing fine, probably have a patent airway. Your patient with snoring respirations, with fluid obstructions in their airway, absolutely they do not have a patent airway. OPAs, or oropharyngeal airways, are those first-line airway devices that go in the back of the throat to keep the tongue off the back of the throat. NPAs, or nasopharyngeal airways, are those soft tubes that go in the nasal passages. We can actually use 2 of those if we want. For what it's worth, you can use 2 NPAs and an OPA if you really need to. Finally, a bag valve mask, or BVM. Bag valve referring to the bag that we squeeze, the mask referring to the actual face mask that goes on the patient. This is not an exhaustive list of the terms you want to remember when it comes to airway management, but these are some really important ones that you want to easily recall. So a quick review of everything we have gone over today in this course. Please always remember that airway management is a fundamental skill in emergency medicine. Skill that we want to be the best we can at. A skill we want to practice as frequently as possible because it's the most important treatment priority in the vast majority of our patients. We always continuously reassess the airway. This is not a one and done type of procedure, assessment and manage. This is continuous assessment, continuous management of a patient's airway through the duration of our patient contact, from the time we walk into their house to the time we deliver that patient to an emergency room. Proper positioning, proper airway opening, suctioning, and airway adjuncts are the big things we need to understand. Airway management starts with putting them in an optimal position, opening their airway, removing any fluids, and using any adjuncts that we need to secure that patient's airway. And finally, practice, practice, and practice, right? You can only get good at these skills by performing them. Practice on mannequins as much as you can. Get as much hands-on experience in clinical rotations as you can in airway management, because it is a fundamental skill in emergency medicine, arguably the most important thing that we do, and something that needs to be practiced to perfection. So that will be the end of the course today. I hope this offers a good kind of introduction into basic airway management. Remember, this is just an introduction, right? This is a set of skills you're going to need to continue to learn and perfect upon for the duration of your career, even once you're out of EMT or paramedic school. This is an introduction into basic airway management. Hope it was a helpful course. Have a great rest of your day.
All right, now let's transition into some multiple choice questions.
Which of the following is most commonly used to treat patients experiencing respiratory distress secondary to pulmonary edema? Your answers are non-rebreather mask, nasal cannula, CPAP, or nebulizer? The answer is CPAP. CPAP is often used for patients experiencing respiratory distress secondary to pulmonary edema because it's a non-invasive form of positive pressure and helps to hold open the alveoli and push fluid back into the vascular space. Why do patients with emphysema often have pursed lips when exhaling? Select 3 correct answers. Your answers include: helps to increase the pressure in the airways, keeps the airways open, helps release trapped air, prevents too much air from escaping, and helps to decrease pressure in the airways. Pursed lip breathing can often be seen in patients with emphysema because it helps to release trapped air by increasing the pressure within the airways, specifically the alveoli, to keep them from collapsing and trapping more air when they breathe in again. So your answers are: helps to increase the pressure in the airways, keeps the airways open, and helps release trapped air. Which airway structure, responsible for clearing germs and debris from the airway, is damaged in patients with COPD? Your answers are bronchi, cilia, alveoli, or bronchioles. Cilia are hair-like and line your airways. Their job is to move germs and debris from the airway. In patients with chronic bronchitis, the cilia are destroyed, causing excessive mucus production and lung infections. However, it is important to note that the alveoli and the bronchioles experience damage too, but they are not specifically responsible for clearing debris. Your answer is cilia. Question 4. Which lung sounds are most commonly heard in patients with asthma and COPD? Your possible answers are wheezing, rales, rhonchi, or stridor. The answer is wheezing. Wheezing occurs from constriction of the lower airways and is generally heard during expiration. Next question. Of the choices, select the 2 diseases that fall under the umbrella of COPD. Your answers include emphysema, CHF, pneumonia, and chronic bronchitis. The 2 main forms of COPD are emphysema and chronic bronchitis. Chronic bronchitis causes excessive mucus buildup, inflammation, and narrowing of the bronchioles and bronchus. What are the spaces between the ribs called? Your answers are intercostal muscles, intercostal neurovascular bundles, subcostal muscles, or intercostal spaces. The answer is intercostal spaces. The suffix inter means between, while costal refers to the ribs. Which of the following patients is most likely to experience a spontaneous pneumothorax? Answers are a patient with COPD, a 6'4", 25-year-old male who smokes, a female between the ages of 30 to 40 who smokes, or a patient with BHD syndrome. The answer is a 6'4", 25-year-old male who smokes. Tall, thin males, as well as those who smoke, are more prone to spontaneous pneumothorax. Next question. Which anatomical landmark marks the division between the upper and lower airways? Your answers are the carina, the hyoid bone, the pharynx, or the larynx. The answer is the larynx. It sits between the pharynx and the trachea and is generally considered the point of division between the upper and lower airways. When inserting an oropharyngeal airway in an adult patient, you should be sure to do which of the following? Answers include initially insert the airway sideways, then rotate it 180 degrees. Depress the patient's tongue and insert the airway sideways initially. Ensure the patient's tongue is not depressed and insert the airway upside down initially. Or depress the patient's tongue, insert the airway upside down, and then rotate it 180 degrees. The answer is depress the patient's tongue, insert the airway upside down, and rotate it 180 degrees. The best method for inserting an OPA is to depress the patient's tongue and insert the airway upside down, pointing up towards the hard palate. When the OPA reaches the soft palate, rotate the airway 180 degrees until it rests against the lips and teeth. Last question. Which of the following joins the pharynx with the trachea? Answers are hyoid bone, esophagus, larynx, or vallecula. The answer is the larynx. The larynx is a complex structure that joins the pharynx with the trachea.
Thanks for tuning in to EMTprep Pulse Check. If you found today's episode helpful, be sure to subscribe, leave a review, and share it with your classmates and crew. For more test prep tools, study guides, and practice exams, head over to EMTprep.com. Until next time, stay sharp, stay safe, and stay on pulse. Thanks for tuning in to EMTprep Pulse Check. If you found today's episode helpful, be sure to subscribe, leave a review, and share it with your classmates and crew. For more test prep tools, study guides, and practice exams, head over to EMTprep.com. Until next time, stay sharp, stay safe, and stay on pulse.